Ladies and gentlemen, please take your seats. Our program will begin in 5 minutes. Ladies and gentlemen, please take your seats. Our program is about to begin. Ladies and gentlemen, please take your seats. Our program is about to begin. Ladies and gentlemen, our program will now begin. At this time, please silence all cell phones and mobile devices. Thank you.
That we've had thus far, and believe me, organizing this is like planning a wedding every single year. Over the next 3 days, we're going to be working to align with the new key priorities that our administration has set. We are working to reduce the opioid crisis, reduce burden, align our work with the CMS meaningful measures, and we are going to be constantly learning from each other.
And we really need to focus on how we can work together, take some of the best practices we learned from this morning, and figure out how as a team we can work together across all of the quality partners in our states to improve and reduce the opioid epidemic.
Just imagine if every one of you in this room would do over the next 3 days, say 5 commitments each. That would result in 13,000 commitments by the end of the day on Wednesday this week. The other things we want to ask of you, and this is a request right now, is to embrace change. You know, the healthcare system is changing rapidly, the payment systems are changing rapidly. A lot of people and a lot of our fellow clinicians are suffering because of it. But embrace the change and move toward the change.
Most of the work we've done thus far in opioids has been really process-driven, but I think that having that data will let us start to see the outcomes and see whether or not we're actually achieving it.
So since we've come into office, we have been working to put patients first. And we set forth to accomplish 4 main goals at CMS. First, improving the customer experience. Second, ushering in an era of state flexibility and local leadership. Third, supporting innovative approaches to improving quality, accessibility, and affordability. And fourth, empowering patients and doctors to make decisions about their health care.
We're here in year 4, and there's still much to be done. We'll roll up our sleeves and continue the fun. With brains in our head and feet in our shoes, we'll steer ourselves in the direction you choose. We'll stay on our journey, we'll learn, and we'll grow. Dr. Seuss said it best, "Oh, the places you'll go."
Please welcome Dr. Rena DeSaja, Director of the Division of Quality Measurement in the Quality Measurement and Value-Based Initiatives Group Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services.
Good morning. Welcome to day 2 of the CMS Quality Conference. How is everyone doing today? What a great first day that we had. Next slide, please. So the first day was full of motivational talks, and we really had this call to action. From our day 1 social media highlights, I want to share a few stats with you. Nearly 1,700 tweets came from 352 participants. We had 8.1 million impressions. And hashtag CMS QualCon 18 was the 6th trending healthcare conference from yesterday. One of my most favorite tweets when I was looking at the Twitter feed yesterday was this one. This was summarizing the themes of partnership with patients and this graphic facilitation based on Jill Zimmerman's talk, for the Partnership for Patients presentation. And you can see here themes that popped out that we've heard yesterday, including the importance of the private-public partnership, how everyone in this room needs to be involved, and the importance of this learning collaborative being so important. Next slide. Yesterday morning, we heard a call to action. Janine Alugo told us to steal shamelessly from colleagues and partners to educate patients, and this would lead to great outcomes. We also heard that to truly create sustainable change will require a partnership between patients, families, and providers. And we also had a charge of a commitment. We can create a culture that helps us to work together. Paul McGann charged us with making a commitment. We have over 2,600 participants today, or this week, at the Quality Conference. And if each of us makes 5 to 10 commitments, we can get 26,000 commitments before we leave tomorrow evening. I'd like to see a show of hands of how many people have made commitments since the start of this conference. That's quite impressive, and imagine what we can do. But we were also told a commitment is not enough. We need to take that commitment and actually translate that to action. And Dennis Wagner charged us with being able to take those commitments and make requests and offers. Next slide. We also heard from our CMS administrator, Seema Verma, about the prioritization of putting patients over paperwork. She shared some important quotes that I think resonate with all of us. This includes that when a provider has to spend more time looking at paperwork and not being able to engage with patients, that it actually takes away from delivering care. There's a fine line between regulatory benefit and regulatory burden, and we need to have a culture where doctors and nurses are at the front line treating patients and not filling out forms and checking boxes. She also shared some early successes for us about reducing regulatory burden. I want to share those statistics with you again today. For hospitals, nearly 500,000 hours of burden reduction has translated to $16 million in savings. In addition, for home health providers, over 2 million hours of burden reduction has translated to over $145 million in savings. Next slide. Similarly, we also heard the importance of providers working with patients in a patient-centric manner to address the opioid epidemic. We heard that CMS is finalizing its long-term roadmap. We have over 11,000 clinicians who have signed the Medication Management and Opioid Campaign Pledge. And we're hoping to have a lot more. We also have heard examples of networks who are using the education and the data to drive improvements in overuse. Sarah Shinar shared in West Virginia that in 2013, with their over 2,700 participants, they have seen a nearly 40% reduction in patients actively using opioids. And of those 2,700 participants that have participated, there's been 0 overdose deaths. Next slide. CMS's comprehensive initiative of meaningful measures was another thing that our administrators spoke about yesterday. This was launched in 2017 and identifies the high priorities for quality measurement and improvement. Its purpose is to improve outcomes for patients, their families, and providers, while also reducing burden. By identifying the highest priority areas for quality measurement and quality improvement, the Meaningful Measures Initiative provides a framework for the core issues that are most vital to providing the high-quality care and improving patient outcomes. Next slide. CMS Administrator Seema Verma also described the 4 goals that are the core to our Meaningful Measures Initiative. And you see that the 4 goals are centered around the patient, and these include improving the CMS customer experience, ushering in a new era of state flexibility and local leadership, supporting innovative approaches to improve the quality, accessibility, and affordability, and finally, empowering patients and doctors to make decisions about their health care. Next slide. This graphic shows the meaningful measures framework, and it shows that we have 6 overarching quality domains which serve to organize the 19 meaningful measurement areas into specific domains. I want to pull out one quality domain in particular that highlights some of the themes that we heard yesterday. Next slide. The strengthening person and family engagement as partners in their care is an illustrative example of where you can see that this overarching domain, goals and criteria and measures are interrelated in the meaningful measurement in priorities. We have 4 measurement areas in this domain, and these include that care is personalized, aligned with the patient's goals. This ensures that the care is aligned with a care plan that is co-created with their doctor and evidenced by people making decisions about their care. The second meaningful measurement area is end-of-life care. According to preferences that we know that over maybe less than 50% of terminally ill patients have an advance directive in their medical record. Third is the patient's experience of care. Recent average positive reports of healthcare experiences show that there's variation in care. So for example, from 52% patient satisfaction for care and transitions, we've seen also 87% patient satisfaction for discharge information. So actively engaging with the patients and reporting their experiences, including satisfaction with care, with staff, and community inclusion are an important area for us to measure. And finally, the patient-reported functional outcomes. A good example to think about this includes the total knee replacement surgery. It's among one of the top 5 most frequent inpatient procedures, and more than 50% of inpatients are actually discharged home. By improving or maintaining the patient's quality of life by addressing their physical functioning, this actually affects their ability to undertake daily activity that's are most important to them, and being able to measure that allows us to assess this area. Next slide. So this meaningful measures framework that we're talking about is really an initiative that draws on a variety of collaborators, many of whom may be in this room today. And this includes the Healthcare Payment Learning and Action Network. This includes the National Quality Forum. This also includes the National Academies of Medicine. And it includes perspectives from everyone, from a wide variety of external stakeholders, including patients, as well as the Core Quality Measures Collaborative, the Agency for Healthcare Research and Quality, and many other stakeholders. I want to leave with thinking about, with this launch of the initiative, that it really comes a need for all of us to reflect on the functioning of our current healthcare system and the continuing challenges as we think about alignment, parsimony, burden, quality improvement, and putting patients at the forefront of care and population management. So in closing, this is really an opportunity for a conversation, as we are doing at this conference yesterday and for the next 2 days, and helping us identifying the meaningful criteria for patients and providers that can lead to a positive change. Thank you.
Now, please welcome Dr. Kate Goodridge, CMS Medical Officer and Director of the Center for Clinical Standards and Quality Center for Clinical Standards and Quality.
It's kind of a mouthful, isn't it? Thank you. Good morning, everybody. Welcome back to day 2. Thank you to Rena, one of our rising stars in CMS. I'm so glad that you were able to hear from her this morning. She's taken a real leadership role in many of the priorities of this new administration, certainly including with meaningful measurement. So I just want to reflect a little bit on yesterday and just to say how wonderful it is every year to come back to this conference and see old friends that I haven't seen for the last year. Many of you I've known for 10 years or more. Some I just met last year or just during this past year. And it's just so refreshing and energizing to come back and spend time with you again. The first year of the conference that I attended back in, I think, 2011 or 12, at the end of the first day of the conference, I came home to my husband. I said, honey, I found my people. So you are my people, and it is great to be here with you. So what I thought I would do today is reflect a little bit about yesterday, what you all heard from Administrator Verma, and then what I heard from all of you after we talked a little bit about the new priorities for the administration. You heard a lot about patients over paperwork, meaningful measures. You heard a little bit about the quality payment program. We're in the first year of data submission. You heard a lot about human-centered design yesterday as well. And, I live and breathe these topics every single day. And so in my head, surely everybody knows all about what we're doing with patients over paperwork. They know exactly what we mean by meaningful measures. They totally get human-centered design and how it all fits together. But what we discovered yesterday as the executive team was out and about talking to folks is, while some people definitely have been in the trenches as we've been developing these priorities over the last year, a lot of you still had a lot of questions. You weren't really sure how the pieces fit together. You didn't necessarily have a good insight into exactly what we're doing around patients over paperwork or meaningful measures. So what I wanted to do today is really try to pull some of these things together, to tie them together, because they really are all part and parcel of putting patients first and the strategic direction for the agency and for the work that you were doing with us as part of your networks. So what I thought I'd start with is maybe just a little bit more about patients over paperwork. So as you've heard from what Rena just said and what Administrator Verma said yesterday, this is about reducing administrative burden on providers. But I want to be really clear about this next part. It's reducing burden on providers in service of better patient safety, better patient outcomes, and program integrity for the Medicare and Medicaid program. That is really why we are doing it, right? So how have we gone about doing this? Well, this gets to some of the tools that we have and that you all have been participating in with us around continuous improvement and lean, and yes, human-centered design, which is another tool in our toolkit to continue to improve. We've been listening to our customers. That includes clinicians, people who work in the billing department of hospitals, people on the front lines in skilled nursing facilities, and yes, patients. So we've taken a couple of different approaches, just so you all can hear a little bit about the approach that we've taken to reducing burden in service, again, of patient safety and quality. So one of the first things we did that some of you may have helped us with is we put requests for information in all of our regulations last year, specifically asking the question, what can CMS do very specifically? We needed real ideas here. What can CMS do to reduce burden on providers so that they can spend more time with patients? We need very, very specific thoughts on that. And we heard from you. We got thousands of comments in all of our rules about how we can go about doing this. And over the last several months, we have been spending quite a bit of time going through each and every comment and thinking about what we can do to address that comment. There are going to be some things that we can't do because we worry about the impact on safety or because it would require a change to the law, but there's a lot of low-hanging fruit there. And so I think you'll see from us over the coming weeks and months that through our upcoming regulations, we'll be addressing a lot of your comments. There's also a lot of low-hanging fruit out there right now that doesn't require going through regulation, that we are also figuring out how we can deal with in I think, a more rapid fashion. The second thing we're doing is we're using one of the tools in our toolkit called journey mapping. You heard Seema actually reference this yesterday in her talk when she talked about how she wants the CMS staff and our contractors to be out on the front lines listening to our customers to understand their experiences working with CMS and their experiences taking care of patients. And so this is really, we've really taken, grabbed hold of a number of these new, very evidence-driven, scientific, rigorous tools around human-centered design to really understand our customers' experience holistically, right? It's very easy for those of us who work in the quality measurement world to just look at what it takes for providers to report on quality, and those who work maybe in the survey and certification world to understand what hospitals or nursing homes have to do to comply with our regulations. But if you're a provider or a patient in a long-term care facility, you're not thinking of it in terms of quality measures and quality improvement and conditions of participation. You're thinking about it holistically. What do I have to do to improve care for my patients? And what is the government holding me accountable for? And how can we make that easier for folks? So this has been a really eye-opening experience for us to take this on. Just a couple of examples of things that we've done thus far that really were low-hanging fruit and easy to take care of, and that we've heard from our customers would make a big, big difference. One is for facilities that have to submit plans of correction after getting a survey from either a state survey agency or one of the accrediting organizations. We now allow them to just submit their plan of correction to us in a Word document. That seems like the easiest, simplest thing on earth, right? But before, we made them document their plan of correction in this really kind of annoying way on the actual government form that we send to them, that is their survey report. And my understanding from David Wright, who's our Director of Survey and Certification, is that this one change has gotten him more applause than just about anything else when he goes out and talks to people. So, and then it was so easy. It took nothing to do. The second thing that was actually really easy that we just announced last week is that we now no longer require that attending physicians have to redocument what a medical student documents when they are working with medical students. What we heard from academic physicians, but also community physicians who have medical students working with them is part of the reason that I don't have medical students work with me so much anymore is because I then have to redocument, because CMS says I have to, everything that they just documented. You don't have to do that anymore. You just have to verify that you did the physical exam or you saw the patient with the student. And there are some details under that, but really you do not have to redocument anymore. So we heard from folks, thank you. I'm an academic physician still, and this is a big deal, I can tell you. So that's exciting. Another example of our work on patients over patient paperwork is meaningful measures, what Rena just talked about. As she said, this builds upon really, I would say, the months and years of work that we and you and many others have done to really identify the core areas of measurement that are most important for improving patient care. So it focuses our measurement efforts for really two main purposes. The first is in service of better patient outcomes, right? So reducing administrative burden in service of better patient outcomes. And we know from our experience, certainly with the HIN network around partnership for patients, that if you give providers only a few things to improve on that are really the most important things that they and their patients care about, think about hospital-acquired conditions and readmissions, for example, and you set goals around those things, the improvement and the rate of improvement will be much greater. Hospitals and doctors and nurses cannot focus on 72 different things to improve. So we need to figure out what are the most important areas to improve on. And this in turn will result in better quality of care and hopefully better outcomes for patients. And of course, the second purpose is to reduce the administrative burden on clinicians and other providers and help them focus on what is most important for their patients and not have to spend so much time doing the administrative work. So how are we approaching this? Well, Rena talked about it quite a bit, and I'm not going to repeat everything she said, but I will give you a little bit more of an insight into sort of the direction here. The first phase is that we are going through our existing measures, measure by measure. We are looking at every aspect of every measure. Is it working? Is it actually leading to better outcomes? What's the variation in performance on this measure? What have we heard from clinicians about what it is they have to do to actually collect the data on that measure, and is it worth it? Because what we have heard from clinicians is, I don't mind reporting on measures if it's a measure that's helping me, if it's a measure that's helping my patient. It may actually be worth the burden if it's really a helpful measure. But if it's not, if it's something that's just standard of care practice we're all doing anyway, why do I have to actually report to you on it? So we're going measure by measure to look at that. And thank you. That got me a cowbell. That is awesome. So I think you'll see some changes in our upcoming regulations around that. The next phase, though, is to keep, but also to develop measures that fill critical gaps where we don't have good measures. So a great example of that is a priority for this administration is around the opioid epidemic. So we are looking at developing new measures around the opioid epidemic, really important to clinicians and patients. And then finally, the next thing, and it's not like in sequence, these are all happening at the same time, is to streamline the implementation and work that goes into the data, collecting the data and reporting on the measures. So that it gets back to sort of the human-centered design of going out into the field, listening to our customers, standing by them as they are collecting data and reporting to us. So we have removed several measures from our hospital programs already. There's more to come writ large across all of our programs. We also made clear the glide path to removal of lower value measures and clinical process measures from the MIPS program. And another thing we did is that we actually, working with our partners at the United States Digital Service, they helped us to develop an API for data submission for the QPP program, and we're going to be looking at this across all of our programs that, again, we think will really make it a lot easier for folks to submit data to us. And speaking of the QPP, this is the last thing I'll focus on. We really took an approach with this program because we know it's a huge change for clinicians. That really leveraged, again, many of these continuous improvement principles and listening to our customers. We came at the program thinking about how do we lessen the administrative burden so that clinicians can focus on taking care of patients and not paperwork. One of the big things we did was we developed some new tools and a new website. I know many of you have gotten yourselves very familiar with these websites, particularly as you're working with clinicians on the front lines. This is a website that has a lot of great information and an easy to understand format, but also allows for two-way communication and submission of data. One of the very cool things about this site that we think will address a lot of what we heard out in the field from clinicians is, as they enter data on quality, on improvement activities, et cetera, they will see their real-time initial scoring within that MIPS performance category. That has never happened before. In the legacy programs, nobody knew how they did until 9 months later, or maybe until their payments were being adjusted a year later, and that's not good. I'm going to put in a plug here for the data submission period. It is open now, as many of you know. I know you're working closely with your customers on the front lines to get data in. That data submission period ends on March 31st. We are continuing to develop new features for the site based upon what we hear from clinicians. One that I want to announce today is called the Claims to Quality feature. And this is for clinicians who decided to submit quality data to us using claims where they append a G code or a quality data code. They can now go into the site under their NPI, and they can actually see their quality score based upon those claims. That is also something that is new, and we're very, very excited about. Thank you. And then finally, we've been getting a lot of questions about when are we going to let people know whether or not they're eligible for 2018 since the eligibility criteria changed. People are eager for that, and so that will be available by the end of this quarter. We're working very hard to be sure that that data is accurate, that we're telling you the right thing. We need to be sure that it's as accurate as can be. So that is coming very soon. So thank you all for the work you're doing to help improve patient care, to help with our workforce who is doing everything they can to provide the best patient care, but sometimes we get in the way, and we need your help to understand how we can do our job better. And now I'm going to turn this over to my wonderful colleague, Dr. Deidre Gifford, who is the Deputy Director of the Center for Medicaid and CHIP Services. Deidre.
Thank you, Kate. Good morning, everyone. I didn't get the guy with the deep voice announcing my name to the auditorium, but maybe next year. I'm really happy to be here speaking to you about what's happening in the world of Medicaid quality. I've been to this conference before, not from this position, but as a member of the audience in the prior life when I worked for the QIO program. And just out of curiosity, how many of you in the audience work primarily on Medicaid quality improvement in your day-to-day work? Yay. Okay. Thank you. So it's a minority, and that's understandable, but that lets me know that it might be useful for you all to hear a little bit of an overview about what's happening in the world of Medicaid quality. Obviously, I was reflecting as Kate and Rena were speaking, the role of CMS in Medicaid quality is very different than the role that CMS plays in Medicare for obvious reasons. We partner with states who are the on-the-ground operators of the program at the state level. So CMS has a different set of levers and a different regulatory kind of regime that we use in Medicaid quality. And we have to partner very closely with our state partners, those of you in the audience, and at state Medicaid agencies and other state agencies that work in Medicaid. And so it's a different approach, but I thought I would give an overview of what's happening and what we anticipate happening in the near future in Medicaid. There are 76 million people now in the Medicaid program. That's more than in the Medicare program. We cover half of the births. We're the insurer for half the births in the country, and 40% of children are insured through Medicaid and CHIP. And if I neglect to say CHIP, just assume it's in there. When I say Medicaid, I'm talking about Medicaid and CHIP. It's a separate program, but our quality efforts are focused on both. So let me start with the adult and child core measure sets. This is the sort of the foundation of the work that we do in Medicaid around quality improvement. These are voluntary measures that are reported by states to CMS. We have a core set for children and a core set for adults. The child core set began in 2010. And the adult core set was released, the first sets were released in 2012. Over the years, we have both added measures to the sets, and states have increased the number of measures that they've been reporting. The significance of these sets, and if it's not obvious, is that this is really the first time, beginning in 2010, that we were able to take a look at the quality of care in the Medicaid program from a national perspective. Prior to 2010 and the child core set measures, there was not a standardized way that CMS could look at the quality of care in the 50 states, the District of Columbia, and the 6 territories, and be able to get a comprehensive picture or to compare from state to state. So this was a very big advance. The program began in 1965, and it wasn't until 2010 that we had these first set of standardized measures for children. The way that the measures are selected for the core sets, we work with a broad group of stakeholders through the Measures Application Partnership, which advises CMS on the measures to include in the core sets. They look at measures that are where the performance is topping out. They look at gaps in measures. They look at new and emerging conditions and issues and advise CMS on which measures to include in the sets. And then each year, CMS publishes the results of that selection process. This is our progress in reporting measures in the adult and child core sets, and you can see that beginning in 2010, these are the number of publicly reported measures in each of these sets, and we report publicly on measures that have at least 25 states submitting measures to CMS. So beginning with just 7 in 2010 and up to 21 measures that were reported in 16 for the children and 15 for the adults. So we're making steady progress in the number of states submitting measures, the number of measures that states are submitting. And I didn't mention that in the most recently passed budget, which you may have heard included a long-term CHIP reauthorization, the child core set measure reporting will actually become mandatory for the first time. Cowbell for that one. So this is the progress that we've made in core set reporting. We have now in the adult set, we have 41 states reporting at least one measure. And in the child core set, we have 50 states reporting at least one measure and 45 states reporting at least half. This has been a lot of work and partnership between CMS and the states. When we first began the programs, many of the states did not have the infrastructure available to them. They didn't have the staff expertise, the analytic capability, the requirements of their managed care organizations, et cetera, et cetera. So we have undertaken a long technical assistance process with states to help them identify and report on these measures over time. This is the by measure, the number of states reporting each of them. So we do better. We tend to see more reporting in states that have where HEDIS measures are part of their managed care program, and where obviously the measures that can be collected through claims rather than either a hybrid or a more direct medical record abstraction. And so we see a lot of variation in the number of measures that are reported. And so the real getting down to the performance, this is shows our median performance on the frequently reported child core measure sets, and you can see that there's a lot of variation between measures. And obviously this is the information that we use to work with states to both decide how CMS is going to focus technical assistance with states on measure improvement, and also areas where we need to think about focusing other efforts in CMS. So we have seen some improvement, obviously, over time in some of the measures. For example, we've seen in our preventive dental measure for children, we've seen improvement from 20% up to 40% of children having a preventive dental visit since the time that reporting began. That's been a focus of our oral health initiative and a lot of collaboration between states and CMS, which has resulted in a really significant change over time. And this is the number of states reporting the adult core set measures in fiscal year 2016. And I didn't mention that we've also been working with states on both the adult and child core sets to try to begin to shift from process measures to outcome measures. That's, as I mentioned, a little bit more challenging for states in many cases to collect, but nonetheless, we've begun to see more measures that are focused on health outcomes instead of process in both the child and adult core sets. And same thing in terms of variation in performance across the sets as you would, across the measures as you would expect to see in the adult core sets. But again, this is the information that CMS uses to partner with states to focus our quality improvement and collaboration efforts and to decide where to focus future TA. So we do work with states and to look at what they're doing with their measures and think about how they can partner with their health plans and their providers to improve quality. It's a little bit of a more remote function for CMS than on the Medicare side of things, because we are working with states who are in turn working with providers and health plans. But we do have a number of quality improvement initiatives, a maternal and infant health initiative, which has been ongoing for a couple of years, focusing on birth outcomes. We have, as I mentioned, our oral health initiative, working on improving preventive dentistry for children, which is a really important health issue in Medicaid. We have a number of affinity groups that we bring together around some of these measures with states, and we do quality improvement coaching. And finally, we're working to take these core sets, now that states have done this work, and try to integrate them into managed care contracting and value-based purchasing arrangements at the state level to really try and leverage the power of the core sets to move quality. A couple other things in addition to the core sets that CMS has been doing to work with states on quality improvement, and these are more recent efforts for CMS. Some of you may have heard about a waiver demonstration initiative that CMS has to focus on opioid use disorder. A number of states have applied for this waiver demonstration, which helps them both build out their treatment programs at the state level and also gives them a waiver for certain types of inpatient facilities which normally are not eligible for Medicaid funding. For one of the first times, CMS is taking these waiver demonstrations, which are allowable under Section 1115 of the Medicaid program, and developing a core set of measures that states will be asked to collect, all of the states who are in the demonstration, and report to CMS. This will allow us to see how these waivers are changing the system, how states are performing, and we will be providing technical assistance to states for the first time in collecting and reporting on some of these newer opioid-related measures. So this is a new area of focus for CMS. We're also looking at doing something analogous for other types of 1115 demonstration programs in long-term care and delivery system reform, where we're beginning to collect standardized measures across states, collect them at a national level, and share them with the public. These efforts are just in the beginning stages. We're just beginning to standardize, to choose the measures and work with the states on data collection, but this is going to be a big area of focus for us in our state demonstration programs. You heard yesterday the administrators speak about an era of flexibility for states. Section 1115 demonstrations are a big part of that flexibility, which states are being encouraged to take on. But I think you also heard her speak about accountability as part of that flexibility effort. And so the building out these structured measures for Section 1115 demonstrations and asking states to collect them systematically will be a big focus. Some of you may know about our Innovation Accelerator program, which is a partnership at CMS between the Center for Medicare and Medicaid Innovation and Center for Medicaid and CHIP. And this is a program that works providing direct technical assistance to states on a number of areas to help them advance payment and delivery system reform. But part of what's been happening in IAP, as we call it, is identifying some gaps in measures for the Medicaid program and developing some new measures. So we currently have efforts underway in 4 critical gap areas: reducing substance use disorder, supporting physical and mental health integration, improving care for Medicaid beneficiaries with complex care needs and high costs, and promoting community integration for individuals who are receiving home and community-based services in the long-term care area. So Medicaid, as those of you who work in the area know, serves a very unique population. It's different from either a commercial population or individuals served by Medicare. And there are both services and beneficiaries who are very unique to Medicaid and for whom measures don't actually exist yet. Long-term care in particular is an area of focus. So through IAP and some of our other work at CMS, we're starting to help support the development of measures in those gap areas. And over time, as those measures develop, they may become included in our core sets or as part of our scorecard, which you heard about yesterday, and I'll talk a little bit about in a moment. This is an example of some of the IAP measures that we are working on, which will support that different population and set of services that we have in Medicaid. Another thing that CMS has done is work on a home and community-based survey in CAHPS. This is something that we developed over the last several years and which has actually been now certified, endorsed by NQF. There are 19 measures based on this revised CAP. It aligns with the existing CAP survey, but focuses on beneficiary experience for those receiving home and community-based services. This is a huge advance. We have as many people receiving home and community-based services as we have in nursing facilities. We have a whole lot of measurement going on in nursing facilities and not a whole lot going on in home and community-based services. So this is a really important advance. We have 9 pilot sites that are currently using the HCBS CAPS, and we hope to see this type of measurement increase and more states and programs using HCBS CAPS to monitor quality in their home care services. Another area that we're very interested in focusing on at CMS is what we call health and welfare in our HCBS programs. There have been a number of times that the focus has been brought to HCBS programs in terms of safety and health, and this is a big gap area where we need to start developing more measures and need to start looking at quality in HCBS. So CMS has undertaken a process of beginning to look at standardized measures, again, and home and community-based services, where the gaps are, where we need to develop new measures, how we can provide technical assistance to states and other agencies besides the Medicaid agency that need support in collecting and reporting this type of measure. And so you heard yesterday, I think, about the Medicaid and CHIP Scorecard, which is a new initiative this year. And I think the scorecard will bring together a lot of the quality improvement and measure development activities that I've just described in Medicaid. The scorecard, as you probably heard yesterday, will contain 3 pillars. The first is the type of standard quality measurement that you all are used to seeing and working in, which is what we're calling health system performance, and will be the standard quality measurement on the delivery of healthcare services. We're also looking at 2 other pillars which have to do more with program administrative performance, one at the federal level and one at the state level, which will have more to do with how the program is administered and whether we and our state partners are complying with and meeting our obligations in terms of timeliness and consistency, et cetera. But the first pillar will be reported for the first time this year, probably later in the spring, and will be based on our adult and child core set for the most part. The first scorecard will not contain a large number of measures, but will focus on those domains that CMS and the states felt were the most important to highlight, where we had lots of states, more than 25 states at least, reporting on the measures, and where there was some room for improvement. And over time, what we're calling Scorecard 2.0 and 3.0 and beyond in subsequent years, we envision that the scorecard in all 3 of the pillars, but in particular in the health system performance pillar, will begin to incorporate the types of measures that we've been talking about, areas of importance to the Medicaid program in substance use disorder, home and community-based services, more measures for children and more outcome measures in children and pregnancy outcomes, and all the areas that are specific and unique to the Medicaid program. So look for Scorecard 1.0 later on this year, and I anticipate that we'll be working with many of you as we build out the scorecard and begin to add more and different types of measures. So thank you very much. That's a quick tour through Medicaid quality and quality improvement, and thank you for your participation and your all that work that you do to improve quality in Medicare and Medicaid.
Please welcome Jean Moody Williams.
Good morning, everyone. How are you? I'm going to welcome our panelists up to the stage. Let's give them a hand as they come. Please come on up. Thank you. I just want to start by first thanking Kate for coming up and wrapping things up and putting it all into context. She's just such a strong and inspirational leader, and it is my pleasure to work with her and my other colleagues here in our leadership team. DJ, congratulations. It's wonderful work that's going on, and you have been such the leader in state innovation, and I can't wait to see where that goes. I want to thank all of you for being here. Some of you have been coming for many years, and for some that I've been talking to, this is your first conference. There are some who have retired and they're still here. I'm running into people in the house like, what are you doing here? I think we're going to have an alumni association. But I know that they're here because of their commitment. Even though they may not be working in this day to day, it's because they want to be here with this energy and this excitement that keeps our work going. And I know you've been given a lot of challenges, you've had to make a lot of offers, and you might even be wondering, you know, we do this, but does it really make a difference? Do we really start to see change? As we come and we get excited and then we go back and we go to our day-to-day tasks and responsibilities and deliverables, are we making a difference? You know, I just want to reinforce that while change may take time, it does and it will continue to happen. We have to be relentless in our efforts and never giving up on our goals to make a difference, even when there are bumps in the road. And there will be bumps in the road, but we can't let that stop us. I am a witness that you have to stay patient and keep at it. This is a picture of me from more than 20 years ago. You can tell by the hair. It's okay to laugh. I don't care. Some of you have seen this before. It actually is from my days when I worked at the Michigan, at that time, peer review organization, MPRO, the Michigan QIO. Woohoo! And the reporter, it was the Detroit News, was asking me, and I was, you know, still kind of young and naive, ready to change the world. What is your goal, your professional goal for your life? And I said my goal is to make quality healthcare affordable. That was back then. And I can say some 20 years later, that is still, absolutely still, my professional mission in life. I've not given up on the goal. I've not given up, and the reason I haven't given up is because of people like you. When I see you come to this conference, when I hear about all the marvelous work that you're doing every day between the QIOs and the HINs and the Practice Transformation Networks, the ESRD networks, all of our national coordinating centers, our federal partners that are in the room. You know, I remember in talking about Medicaid, the question that was asked was how many of you primarily work on Medicaid, and only a few hands, because I know many of you work on all of that. Many of you, if we asked that question, how many of you work on Medicaid and Medicare, there would be a lot more hands. But I can remember when I came to CMS I came as the director of the Medicaid, state Medicaid quality program, and I was actually sitting several years ago in the very first state Medicaid medical directors meeting. And core measures was just a dream. It was just thinking about if we even wanted to share any data among each other. And that was a challenge. It took us about a year to get to that. And now to see where you have come, as I looked at the posters and heard the presentation just now about launching scorecards and core measure sets and requirements for the CHIP program, change does happen. Give yourselves a hand for that. Now, I know change happens because many of you have watched my little children grow up through this conference. Every year I show you a picture, I tell you a story about them. Well, they have changed. October was really a really big month for me. My oldest daughter that you see there and her husband had been married for 5 years. In that same month, my middle daughter got married, and in that same month, my youngest daughter got engaged. Now you see my husband there, he's got a strange kind of smile on his face. You know, he's really ecstatic that he won't be outnumbered anymore by the women in the family. But he's also thinking, another wedding to pay for. We didn't think about that when we had 3 girls. And before you ask, no, not yet. I still don't have any grands, but change does happen. So that really brings me to to the plenary that we're here for. I have never been more confident, more excited, just more assured that we will see the change that we are seeking in ensuring that patients, families, caregivers' voices are heard, are respected, are incorporated into developing policy, into crafting measures, making decisions about their health care based on information and engagement. And yes, hear the stories. I know we want to move past just telling stories, beyond telling stories, and I agree with that. I think there's so much for us to do with measures development and policy work and all of that. But I do ask that we never lose that aspect. For it's your stories that really makes your experience with the healthcare system different than the person that might be in the room beside you, in the clinic behind you. Your story is unique to us. It was your stories last year that created this work in which each of you had a different perspective on a part of the healthcare system. And I keep this with me a year later. I always have it with me because it reminds me of the work that you do. It's the story of every person in this room that fell from the person and family engagement land last night as we stopped to take a selfie. All of our folks from the land, give yourselves a hand. These are patients and family. That's a room full of people that have come here to make sure that the patient's voice is heard. I'm thankful that for whatever administration I have worked under, and I've worked under several now, I have never been asked to compromise our pursuit of strengthening the patient's voice. You heard it from Administrator Verma on yesterday, and you heard it all through the day, stressing the patients over paperwork and our commitment to not only reducing burden, but to improving the beneficiary experience. I will soon be leading work for the agency on the beneficiary experience. It has to do with some of the human-centered design work that you've been hearing about. We're going to be looking and talking to the beneficiaries, and as you navigate the health system, to map that journey, to see where we can document and reach out and make changes in that journey of the things that we know are causing you pain or difficult to work through. And I bring this up because we're going to be reaching out to many of you as we try to document this journey. And I hope that you will take my call when it comes and work with us as we try and map out this journey. When we ask, I know you'll work with us, because when we ask, you tell us. Most of the time, the patients and families and advocates are not shy. They have something to say, and they let us know, either through our RFIs, our requests for information, our listening sessions. We do many focus groups. What we hear is that you want to be involved in developing advanced payment models. After all, they're being developed to provide care to you and your families, and you want your voice to be integral in how they're designed. Makes sense to me. Patient-reported outcome measures, that they're incorporated in all the measure sets that we have. But what I've also heard is don't just stop with measures. Also incorporate our information, incorporate our goals, incorporate the things that are valuable to us. I heard that we want to make sure that improvement activities in our quality payment program are meaningful, that they're not just something you check the box, but that they really are advancing patient and family engagement. And also that information for technology's sake is just not good enough. That you really are looking for technology that's going to support your decision making, that's going to support you charting your progress, and that's seamless. The burden, we want to reduce the burden for clinicians and for getting patient information. And I believe, and we've had several of these discussions, we're not far away from that. So as we go to our panel today, I'm going to let them tell their story of why they're on the panel. But one thing I want to note is that our panelists are very diverse. They represent, we have Amy Berman from the Hartford Foundation. She brings the voice of the advocate to life in many ways. I'll let her tell you how. We have Marianne Sterling, who's a caregiver and advocate and doing work all across the country. And we have Roger Wells, who's a clinician, a physician's assistant that works with our clinician champions. And he will bring his story because, you know, we can't have these separate discussions where patients are here and clinicians are here and payers are there and somebody else is there. We need to be together and have these discussions together. That's true engagement. That's true partnership. And we are going to do a little bit of this today on the stage, but this afternoon there's another session at 5 o'clock where we're going to continue the conversation. So why don't I just turn first, and maybe I'll turn to Marianne, and she's going to give us a very brief description of what brings her to this work.
All right, Jean, this has got to go up a little bit. Good morning, everybody. So I'm going to start off with a little story today. In the spring of 1974, a 7-year-old girl went to school one morning. It was like any other day, except her mom told her that she might be a little late picking her up from the babysitter's house because she was going to the hospital. In fact, her mom didn't show up until days later. She'd gone in for a breast biopsy, and the surgical team had done a radical mastectomy. That 7-year-old was me, and my mom's health journey would be a lifelong partnership. She would eventually be a 2-time 42-year breast cancer survivor and caregiver for my dad. He began showing signs of dementia when I was only 13 years old. Little did I know that my husband and I would eventually have 3 out of 4 parents impacted by dementia, or that our healthcare system is ill-prepared to deal with this disease. We have done 2 Medicaid spend-downs to date, and we're preparing for a 3rd. Why? Because the only affordable option for our frail loved ones in the later stages of dementia is a long-term care facility that accepts Medicaid. Because dementia care is not covered by Medicare. And affordable home and community-based services are still out of reach. In some communities, non-existent. As my mom declined in her late 70s and 80s, suffering 7 major falls and 13 broken bones, I became her advocate and her care transition team. I often missed work for days or weeks at a time to manage transitions from acute care to post-acute care to long-term care. When I wasn't there, mistakes were made. Her medications were never correct. And of course, paper records still dominate post-acute and long-term care. Like most family caregivers, I was a care coordinator, a medical record keeper, a medical decision maker, an insurance navigator, and that was just a typical day at the office. Did I seek out support? Oh, you bet I did. Programs like the Area Agencies on Aging, as you all well know, are underfunded and overwhelmed. In fact, when we sought the assistance of an ADRC in Northern Virginia to find an assisted living facility for my mom, they sent me this, and I brought a visual aid today. This is a spreadsheet. It's 9 pages. It's on legal-size paper. It has the names of 314 assisted living facilities in the Commonwealth of Virginia and their phone numbers. This was what I got for help. I will close with a story that has haunted me since I lost my beautiful mom 21 months ago. 2 months before she died, I was told by a hospice nurse that my frail, bedridden mom with multiple compression fractures of the spine didn't medically qualify for hospice care. I was dumbfounded. I stood in her hospital room dumbfounded. We had nowhere to go. The hospital wanted to discharge her, and there were no Medicaid beds available in any nursing home in the Commonwealth of Virginia. And it got worse. 2 weeks before she passed away, we were assured that she would have around-the-clock hospice care. It didn't materialize until the day before she died. My mom had the best care that hospice had to offer for 21 hours. I was empowered. I took ownership. The healthcare system failed my mom at every turn. As an advocate, people often ask me, what do family caregivers need the most? Some of you have asked me that. We need a healthcare and social services infrastructure that is easy to navigate, that is flexible, that is affordable, and relentless in its person-centeredness. And family caregivers have the knowledge and experience to help design it. We are ready to be your partners. Thank you.
Good morning, everyone. My name's Amy Berman, and I'm a senior program officer at the John A. Hartford Foundation in New York. We're a foundation that's dedicated to improving the health of older adults. We've invested more than $500 million, with a B, $1 billion, into the models of care, the evidence, the things that you are doing around falls, around transitions of care, around reducing avoidable rehospitalization, delirium. All of the things that you're doing, I can tell you, we are the source of many of those interventions that you're doing. And I applaud you all. I also am here as a person who lives with stage 4 cancer, terminal cancer. Let's be exquisitely real. 7.5 years ago, I was diagnosed with stage 4 cancer. And I was told that the prognosis was about 11 to 20% survive to 5 years. That's right. What that means is that it was highly unlikely I'd live to 5 years. And I told my clinical team what I wanted was to feel as well as possible for as long as possible. I wanted Niagara Falls. Good, 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 then drop off the cliff. Well, I went to another team to get a second opinion, as many people do, and that team wanted to throw every bit of care that they could at me. They wanted to do the most intense chemotherapy, mastectomy, more intense chemotherapy, radiation. They wanted to drop me off the cliff, and I would go out to the same endpoint, because there's no cure for my disease. Well, I chose Niagara Falls, and today I've lived 7.5 years, well past the prognosis. I feel like I look. I work hard. I play crazy hard. I have a great life. And get this, I've saved about $1 million to date. Yeah. So, because my role is also as a senior program officer at the John A. Hartford Foundation, which has invested all of this money to try to figure out how to improve the care, the outcomes, the quality, through evidence-based approaches for older adults, we decided that we were going to use this same person-centered approach in developing out what we call the age-friendly health system across all settings of care, hospital, home care, nursing home, primary care. If we could look at essential elements of care and consistently deliver on the promise, improve safety across all of these settings in the same way, we would get outcomes that first and foremost relied on what matters to the person. There are 4 M's in this model. And mind you, we took these models apart, everything that we know today, with leading developers of these innovations, people like Eric Coleman and Mary Tinetti, the people who have developed a lot of the things that you're doing. And we worked also with health systems, Ascension, Trinity, Kaiser Permanente, Providence, St. Joseph, Anne Arundel, some big health systems around the country to make sure that what we were doing was feasible within healthcare, that it worked for clinicians. And we came up with 4 M's. These are the basics. What matters, that's everything. If we don't elicit the goals and try to do care toward those goals and avoid things that are harmful to those goals, that's everything. Then we have medications, focusing on deprescribing, reducing polypharmacy. Mentation, managing people who have cognitive impairment and avoiding delirium. And mobility. And I say mobility instead of falls because mobility is the thing that decreases everything from falls to improving the condition of people's skin to improving even their cognition. It all feeds together. These are not 4 separate areas. They all work together. Many of you are going to be struggling. What are the basics that I can be doing that are going to get me the greatest value? For those that are interested in joining us in this movement that we're doing with the Institute for Healthcare Improvement, the American Hospital Association, I believe Jay Bott may be in the room. Jay, if you're here, put your hand up because we are so appreciative. Catholic Health Association is also involved in this work and the Joint Commission. If you want to come and join us in this movement, we will help make this easier for you and to meet these goals. Because first and foremost, we have to get it right for the people we serve. There need to be more people who live the experience of getting it right, because when we do, all of the needles move in the right direction. Thank you so much.
Good morning, ladies and gentlemen. We all have a story. We all have a story of a hurt in our heart, whether it be your father who was asked never be in a nursing home. Don't, please, never put me in a nursing home. Please don't do that. And he goes to the nursing home. And you get a call that says, well, he's not doing very well tonight. And the next call, he said, well, he passed away. Or you might be your mother who had chronic disease and had atrial fibrillation and all kinds of issues and finally passed away because of congestive heart failure, but you never knew it because no one talked to you about it or what was going to happen. And as a healthcare provider in the middle of a small community, we see that, but there are friends and our family. But what's happened over the last 2 years as this initiative has gradually progressed is the most profound and enjoyable practice that I've ever had in my career. Why is that? Because we found that with all the measurements that we're doing, 54% of my time as clinician was found to be in front of a computer screen and not with the patient. 54% was all about pushing a button and clicking a page to make sure I hit the right quality data. And I was worried about the administrative duties such as pre-authorizations, Family Medical Leave Act, faxes and insurance, medical coverages, the staff policies and the CME and the credentialing and the home health and the hospice and the nursing home requirements. Oh yeah, I have a family once in a while. The number one problem we're having in healthcare within the provider aspect is the provider burnout. How do we get this far? Who cares? The thing is to look forward, as we were told yesterday, to empower ourselves to think differently and quit feeling sorry for myself because something's bad. I'm in medicine to practice because I enjoy taking care of patients, and I found that by putting the patient first and not worrying about the little details of being quality and improvement, you know what happened? It's become the most enjoyable time in my career in medicine by putting patients first. How do we do that? I believe we're all looking for the great aha and the smile and refreshing love for providing care, whether it's to our family or to a patient, and we have that God-given gift to give. And that's why we're all here today. We're not here to make it burdensome or to hurt people. And so by putting patients first, we find little nuances that make me feel satisfied and very, very comfortable when I go home at nighttime. Whether it's a 6-hour day or a 16-hour day, I feel good. We had a 90-year-old female that came into the clinic one day, and she had fallen 4 times. She was hospitalized, went to this skilled nursing facility, went back home, put her on home health, didn't follow the directions, was getting help from a cardiologist, nephrologist, neurologist, etc. And finally, the family came in and says, Roger, something's wrong. She's getting worse by the week. We have come back. One was from Colorado and one was from another state. And they both came back, and both Ruth and Carol sat down and talked to me during these visits, says, something's wrong with Mom. Something's wrong with Mom. So the 2 daughters found that when they stayed with her over that week, she wasn't eating, she wasn't doing social events, she was falling asleep all the time, she wasn't following the directions of the physical therapy program, she couldn't even remember if the therapist had been there or not. And we finally intervened and said, okay, what do we want to do for you? You're 90 years old, and she said, I want to stop. I want to stop all this coming to provider every 1 or 2 days and getting hurt all the time. So by putting the patient and the family and the people first, what we did is we took her off 2 blood pressure medications, a statin medication. We took her off antidepressant. We took her off another medication that the cardiologist wanted to use because she was having orthostatic hypotension for $900 a month. $940 to be exact. Non-covered. She's in the nursing home about ready to be dismissed to go home. She's walking, she's talking, her activities of daily living have improved. She's going to get by with home health, and she feels great. Why? Because I listened to the family. It is one of the most enjoyable things. It's one of the most enjoyable times. And so when I look at all the acronyms, QIM, MIPS, QPP, QID, whatever, smart technology, I look at putting patients first and being engaged with these families has given me the most rewarding healthcare opportunity I've ever experienced. And ladies and gentlemen, I think when we go through this, if we go to the providers and we sell our issue as being more satisfied at the end of the day, more comfortable with your patient care, and not worrying about whether they're going to go into the RT, the OT, the diabetic T, that takes care of it. So what we started then was a health and wellness center in a town of 2,000 people that we have balance and mobility and walking and social and educational programs for these people that we're listening to and developing healthcare opportunities with tremendous results. Not worrying about the dots and the clicks because they took care of themselves. Because of your guidance and your help, I still do that. But not with the remorse and the anger that I used to feel, because I put patients first. You're on the right track. I applaud you, and keep it up. Thank you very much.
I always resist the urge to say, amen, amen. But it's, you know, we bring this information to you. Number one, to let you know, as Roger said, we're on the right course, but we also have a lot of work to do. We still have patients and families that are slipping through the cracks, through the canyons. And it's through our continued effort, our relentless spirit, that we will achieve our goals. And putting patients first is not just a motto or a logo or a symbol, but the way we live our lives. Thank you all, and please join us later as this panel will continue at 5 this afternoon.
Thank you, thank you, thank you.
Thank you so much.
Wow.
Ladies and gentlemen, that concludes today's panel session. Be sure to visit the gallery walk immediately following this session. Poster presenters will be available at the gallery walk on level 4 until 10:15, engaging with meeting participants and answering questions. Thank you.